I'm going to go ahead and ask the two speakers we have to introduce themselves. We are planning to be joined by a third colleague from Kentucky as well, and I'll pass it to Fran later when she's able to join us. Dafina Ward, would you mind going ahead and introducing yourself first?
Sure. Thank you for having me. Good afternoon, everyone. My name is Dafina Ward, and I serve as Executive Director of Southern AIDS Coalition. I use she, her pronouns. I am based in South Carolina. Just quickly, for those who aren't familiar, Southern AIDS Coalition was founded over 20 years ago by folks who were doing the work on the ground in Southern states from public health and community, who recognized that there was a lack of urgency from a federal lens around addressing the Southern HIV epidemic. And so through years of dedicated policy advocacy and engagement and coalition building, SAC has been doing the work over the past couple of decades to demand more resources coming into Southern communities to expand conversations around HIV and a range of intersecting issues. And we do that through our advocacy work, grant making, leadership development, convenings and conferences, and a number of special partnerships. And really glad to be here. So thanks for having me.
Thanks, Dafina. And Shannon, would you mind introducing yourself?
Hi, I'm Shannon Hicks. I am currently a youth substance use program facilitator, substance use prevention program facilitator, and I'm also a harm reductionist with the Exchange Union. I'm in school full-time working to get my BSW and plan to be able to focus on macro social work, but really boots on the ground, community health, harm reduction is my passion. And I've seen what this epidemic is doing to our community, and it's not just, the people who are unhoused. It doesn't discriminate. It hits everyone. And I think that's one of my largest messages I want to get out there is, we have to talk about it. We have to destigmatize it and educate people about it if we ever want to slow down the ungodly number of people who are dying and getting HIV and hepatitis in our area.
Yeah. Yeah, Shannon, y'all are doing, I know, such important work. And I actually think, in a lot of ways, you being one of our speakers to close out the year really speaks to some high-level priorities at Community Education Group. Folks know who've been with us in this monthly stakeholder meeting for a long time. This group actually started as the West Virginia Statewide Stakeholder Coalition with a focus just on work in West Virginia. And as our work shifted and as we came to understand the region a little bit more, realized that it didn't make sense to create artificial silos, right? Even along a state line, and that we needed to be bringing folks from across the entire Appalachian region together for these conversations. Shannon, you're in, sort of the Panhandle area. Can you, talk a bit about what your work looks like on the ground? And do you see that in your day-to-day work, right? Are y'all serving folks from multiple states and regions when we think about that Panhandle area of West Virginia?
I am in the Panhandle, and there are not so many people from other states coming into West Virginia because our harm reduction laws in particular are so strict. But those who are in West Virginia, I'm speaking with some of the doctors, and they're saying that before they would never see people who tested positive for HIV come into treatment. It was maybe 1 in 10 had hepatitis, but now they're seeing more and more people with HIV. Hepatitis rates it's at least 2 in 10 that come in, and it's from all walks of life, which I know a lot of times we think it's the unhoused, the people living in tents who are sharing supplies, but this is, going from the unhoused all the way up to the people working full-time jobs, nice house, nice car. And when I'm on the ground and I'm telling people you have to be careful, West Virginia is in the midst of an HIV outbreak, nobody's heard about it, and they're shocked to hear about it. And, you know, it's just very frustrating that our state isn't doing more to protect its citizens. And I mean, if you go to neighboring states, there's, even if they're not the best, there are still better policies in place that help address this issue. So it's very discouraging, and it's very difficult. And then with the advent of xylazine, we're seeing more and more xylazine wounds, which aren't like normal abscesses. They're from the inside out, skin grafting, hospitalizations, and it's just, we're definitely in the midst of a crisis.
Yeah. I mean, yeah, I think those of us on the ground, right, experiencing this work across the region know that it is a crisis, right? And that, you know, we see at CEG, right, one of our jobs to be consistent, you know, advocates for the region, bring in resources, and, you know, keeping up the mantle, right, of what a critical need there is. You know, Dafina, can you talk a bit about kind of the HIV piece of this, right? When we think about sort of the layering of HIV, viral hepatitis, and substance use disorder. And again, we wanted to prioritize some of this HIV conversation a little bit because it's World AIDS Day. It was December 1st. And I think, you know, December often serves as a moment to really lift up the work of HIV treatment and prevention. You know, what are you thinking about in terms of having marked World AIDS Day this year, and what we should be thinking about from an HIV perspective headed into 2024?
Yeah, thank you for that. And thank you, Shannon, for what you share. I couldn't agree more with everything that you said. You know, this year, the theme for World AIDS Day globally was let communities lead. So I love that we were also talking about this in the context of community health workers and community-led solutions. And then from the federal level, the theme was remember and commit. And it's interesting because when we think about this idea of HIV and AIDS in this country at 40 plus years, remembering means that we have to reflect on what we've done that's worked, and maybe what we've done or are doing that isn't working. And so it's committing to doing things differently. You know, we have for so long done this work in silos. We talk about HIV over here, then we talk about hep over here, then we talk about substance use somewhere in the middle sometimes. And then we only talk about it in the context of certain people and substance use and the way they utilize substances. And we are not allowing ourselves to have these comprehensive conversations and making comprehensive demands that are inclusive of the full range of folks' needs. And so as Shannon was talking, I was thinking about, you know, the time I recently had the opportunity to come to West Virginia, and in talking about the increased rates of HIV and how those transmissions are happening, those aren't conversations that we're seeing happen, right? We're not talking about injection drug use as a means of HIV transmission. The conversations tend to be about certain activities, certain means of transmission, and that's where we want to put the focus. And I think it's a missed opportunity because we not only are we talking about HIV, the opportunity for HIV, primary HIV prevention that's being missed due to policies, the fact that we are criminalizing folks having access to, you know, clean tools and equipment, that we are criminalizing people even living with HIV when they're seeking support, that we're creating all of these barriers, that we're criminalizing folks, even some southern states, as we're talking about gender identity and trans kids and their families, and just all of these ways that we're making things harder from a policy lens. So you layer that on top of the fact that we have just kind of continuously allowed this work to be siloed, and that the resources that are needed to address the greatest needs on the ground in our communities aren't getting to the folks that need them, that they're getting caught up in high level spaces, that we have federal programs that should put dollars into the hands and to the pockets of organizations that are closest to the need and likely closest to the solutions. But there are so many barriers in place that keep the resources from getting there. So that's kind of what's come up for me just at first, just thinking about this, that we have so many missed opportunities, and that spaces like this need to exist more and should be more of the norm, where you're talking about what a person's full life experience looks like and all the things that they need to be healthy and to thrive, and not forcing folks to jump from place to place to get what they need and make it so complicated.
And Dafina, you know, I know we did at Appalachian Partnership Consortium sort of a debrief of Pacha, but I would love to hear, you know, what was your experience like being in Charleston, right? I know for a number of members of Presidential Advisory Council, you know, they told me and they told others, they're like, I've never been to West Virginia before. I've never been to Charleston. I didn't know what to expect, but I think some of them had they were surprised a little bit about some of the things they saw.
I really think, I mean, I'll speak for myself, and it was such an honor to be there in Charleston and in West Virginia. I was surprised at the power of the infrastructure of what is happening in the face of so many challenges. You know, I think, you know, there are organizations on the ground in Charleston, and I'm sure in surrounding communities, that are doing tremendous work. And so one, I walked away thinking there is great work happening here that needs to be better resourced and supported. And there's also great work happening here that could serve as a model in other communities, from the work that's being led, you know, the community health worker model of work. I know the CEG is doing a lot of great work, and just seeing the clinics that are happening there. You know, what I really walked away with, and what I've kind of been beating a drum about as Dafina, I have to give the disclosure, not speaking as Pacha, but speaking as Dafina. But what I've been beating a drum about are a couple of things. One, really seeing the harsh reality that our free and charitable clinics are paying full price for medications, while FQHCs, other entities, are getting these significant discounts and rebates. That finding out what a barrier that is to folks who we know are uninsured, that don't have resources, getting the medications that they need. So that was one thing. Secondly, walking away recognizing the barrier that's created when federal funding is so geographically limited in a region like Appalachia, right? So when we're talking about, oh, well, this can only be used for West Virginia, and that can only be used for Kentucky, et cetera, the barrier that creates, and that's effectively building a cohesive system of care that's really going to meet folks' needs. So I walked away, those were my two salient points that I walked away wanting to see how we can create change around, because I think it's important for us to be able to name what's working, what's facilitating great things happening, and where the barriers are, and where there are barriers that we may have some strategies that we can implement to reduce, so we can improve the way that services are delivered, and improve the way the resources are being distributed in a way that so that they're getting to the folks who can do the most with them in the communities with the greatest need. So.
You know, you brought up a good point. You know, the bureaucracy of it all. And there's so many grants out there. They're like, hey, we're giving all this money. But by the time it trickles down from, you know, the top all the way down, the people who the money was originally intended for, they get pennies on the dollar, if that. And another thing I've noticed, especially in Appalachia and especially in West Virginia, is there's so much competition between organizations. And I think if we could get that competition out and collaborate, we would be able to accomplish so much more. And I know it's not unique to West Virginia, but I see it more so within West Virginia organizations than in other states. And it's really heartbreaking. And I'm not quite sure. I guess it's more platforms like this is the only thing we can really utilize to try to, you know, collaborate more and stop competing, if that makes sense. I don't know if you've noticed that as well, but.
I mean, I think what we've seen in nonprofits, I've seen it in other places outside of West Virginia too. The competition, it's like Hunger Games, right? Trying to get money into your organization to do the work. And it's crazy because everyone's trying to do important work. But it seems like we have created this system of like this whole, this feeling of scarcity in nonprofit spaces that makes folks feel like they're always clamoring. And they're not just feeling like it, they are like always clamoring to get these dollars or begging for resources that the data and everything else is telling us what's needed. And then we make it so hard to get the dollars where they need to be. So yeah, you're absolutely right. Yeah. I think if we would make it easier for organizations to collaborate, that's one thing, because a lot of these funding opportunities create that crazy hyper competitive thing that's not even about who can do it best as much as it's about, well, we need to get that because we need that indirect so we can keep our doors open, so it's not, so it's, so I think, there have to be more collaborative funding opportunities, and more opportunities that do reflect and require a community-led response in the way that the work is done, the community-oriented response. And, and I talk to folks who've been doing this work for decades, they talk about the fact that, like, we used to be able to do what the community needed us to do. We could feed people. Like, we could do basic things with those federal dollars. We can't even give people a meal, right? So, like, thinking about how do we create funding mechanisms that truly do reflect what a community needs in order to be healthy. I mean, that is really like what it's coming down to. And so, yeah, it resonates, everything you've said, but that is the spirit of competition has created this like scarcity thing in our organizations that's led to this spirit that's not really supportive of meaningful collaboration that we really need.
And I think I know in West Virginia in particular, we get a lot of kickback just from misinformation and not being educated about communicable diseases, about substance use disorder, about harm reduction, and the fear mongering and misinformation. It causes there to be even more barriers and blockades than there needs to be. So
yeah, the stigma. That stigma is real, and I can imagine that when we're talking about substance use disorder, that's there's all these layers of stigma. Our colleague Gina Brown calls it the onion of stigma, right? Like, there are these layers people are dealing with, and they're dangerous and harmful, and we have to be real about that, like how that's showing up in folks' lives, and that there are so many different things that have to be addressed. And I know, folks are familiar with no wrong door, that concept from Samson, this whole idea of like, whatever door I knock on should be able to get everything that I need. And that's not, and I don't think we've created like structures that really do that, or that creating more funding mechanisms that really support that. So when folks are walking in with all these layers on, can I come to one place so those can start being peeled back, so that I can achieve, whatever health looks like for me, so that I can achieve that. Yeah.
Well, I want to bring our third speaker in for today. Fran Feltner is with the University of Kentucky and their Center on Rural Health. Fran, we've been talking a little bit about our community response to this overall syndemic of HIV, substance use, viral hepatitis in Appalachia. Would love to hear from you about, thinking about from your vantage point, both at an academic center, but also, from Kentucky, sort of how you think about this broad work that we're doing to address public health in Appalachia.
Okay, so I've heard a few words. I got on late. I apologize. This was not on my calendar. I don't know what happened, but I'm glad I'm here. And thanks for reaching out to make sure that I am here. I heard words just a few minutes ago about community and collaboration. And I think really and truly, until we work together, I really do believe that we can accomplish a lot if we work together. The stigma and talking about no wrong door. So basically what our community health workers do here with Kentucky Home Place is that we are generalists. They are trained as generalists. And that means that they can take care of any part that a person needs help with. So they're doing, I want to use the word coordinated care, so that not just for the person that is in the middle of that circle, but for the family as well that's on the outside of that circle, that have everything to do with how you improve your health. As a single person, you have all of your family, you have your providers, you have all the different people around you in order to improve your well-being. So I love the concept of no wrong door. So if we have a client that comes in that has diabetes, they may also be a substance use disorder person as well that needs that assistance. And so they are trained pretty much to open the door that needs to be opened in whichever direction it is. And I do worry because we do have, I won't call it a pandemic, but we do have the potential to be the next breakout site here in Kentucky, and have been doing quite a bit of work here in Kentucky to make sure that we educate the folks that need to have education, and particularly our community health workers, to know how to give answers when questions come in. So I think I heard too that work with the community, listen to the community. And I think I said this to you before, but if the problem's in the community, the solution's in the community. And we really do need to work that direction to find out, what may work in this community may not work in another community. It may need to be tweaked, to get the best effort out of our work that we're doing. Also, when you think about funding, in Kentucky, we have passed a bill that funds community health workers reimbursement. Now, I won't say that it's working well at this time because it still has some issues on what reimbursement means for community health workers here. There's like 4 ICD-10 codes that can be utilized in that. They have to be supervised by a particular person, as far as the doctor, the psychologist, a dentist, a licensed social worker, clinical social worker, as far as that goes. But it's just particular things that passed in that bill. And then it's particular CHWs and where they work that can have that reimbursement. So there's still some issues in January when we go back to work on this with legislators that we need to do. But wouldn't it be really cool if we had that across our states, across this collaborative, that we have made those adjustments to be able to support our community health workers other than just the grants? Kentucky is very lucky too, because with our CHWs, they are state funded, partially funded by state dollars that come through our public health department there. And this was done through our legislative bill that was passed years ago that has kept home place in place here. That's pretty good if you got a home place staying in place. That, I like how I said that there. Place in place. It really matters. Place matters. Where these community health workers are employed, if they're part of the community, they understand the community, they understand the people that they're serving, and it makes such a difference in the lives of the people that they serve. Funding continues to be an issue because I worry that, I have a state contract, but I also have grant funding to supplement that to keep all the people working. I also worry that if we have reimbursement, that's all we'll do is what we're reimbursed for. And then we'll need another set of community health workers to do the other side. So I don't want to leave anybody out. And I'll leave you with that thought here with, we're working with Unite, we're working with our ARC delivery system here in Kentucky. And I want you to think about this too. So the person that is in addiction has a stigma of their own, but so does the family. The family needs to really need resources and how to understand if they are enabling their family member or if they're supporting their family member in the right way. And that's one of the things that we're working on in a committee right today, is setting that up so that people that have family members in addiction can come in and tell us what the resources that they need that are not being available to them, not just the person that's being treated. So we've got a lot of work to do from every side. And I think if we consider our community, we consider the family members of the people we're serving, and that we look at the person holistically to say, you don't just have diabetes, you don't just have substance misuse, you don't just have this, because more than likely, they have a little bit of everything that we need to work on. And so, like she said with the onion, you take one thing at a time. What is the most important for that person that you're serving to start with? And then you start peeling back and getting them to understand the different things that they need to happen. And then find those resources for them. Not just identify and say, hey, you need this and walk away. How do you connect them to that resource and then be there as a support system to coordinate the work that they need done? And if we're going to make people live healthier lives, help them to live healthy. You can't make people do anything. You can bring the services to them, you can teach them, you can coach them, and hopefully you have lifted them up enough to be able to do the things that they need to do to improve their health. And so that's a lot in just a little nutshell, and I'll stop at that point. But I appreciate you making sure that I'm on here. I love hearing what you all are working on. And I do think I see the mountains behind you in your screenshot, and I love that. And almost like the onion, we have to cross one mountain at a time. We have to remove the barriers on our way the social drivers of health or the social determinants of health, whichever term we want to use, to get around those mountains, through them, under them, over them, however we need to do to serve the people that need our services so desperately, to be able to improve their health.
No, Fran, we're thrilled you were able to join. And again, I think that each of the three of you, right, comes at this work from a different state, from a different regional focus in Appalachia, and from a different sort of perspective that all, again, you've all spoken to the importance of collaboration, right? If we are all in the same, same sailboat, whatever analogy you want to use, rowing and moving in the same direction, I really think we've got the energy, the talent, the ambition, the time in Appalachia to make a difference when it comes to this public health work. We've just got to figure out how we get those puzzle pieces to click together.
If I could add just one thing to that, when we look at our states, and you brought it up again, so if we look at our states, and when I go to the Kentucky-Virginia line, and I am crossing over that line, it shouldn't change. I mean, there's no big line that says, hey, you cross here and things change. We should be working together. We shouldn't let a state line, border, whatever you want to call it, prevent us from working together on issues that affect all of our people in our communities. And I'm sorry, I didn't mean to interrupt you, but I didn't want to, you said the state, and, I live in Kentucky. Virginia is right across the line from me. West Virginia is like an hour away from me. We still have our people that are going back and forth, and why should we let a state line stop us from working together?
Mm-hmm. Mm-hmm. And we obviously, as part of this syndemic conversation, HIV Awareness Month, wanted to lift up, I know from a CEG perspective, right, this really vital role that community health workers have, right? Folks who I think can really be game changers for community. Want to ask Jason Lucas on our team, who's helped head up our CHAMPS job training program, what opportunities have you seen as we've sort of ramped up some of this training and thought about opportunities for community health workers to address this endemic in Appalachia?
Well, thank you, Lee. I think there are several places where CHWs can be of great use. But I think there are some different moving parts here. I think one of the things that I was thinking about when kind of reading over the description of this event today, and kind of thinking about what we might say or what we might talk about in relation to CHAMPS and CHWs and HIV. So our training program has about 115 hours of core CHW training. That's all the stuff that you'll find in the C3 core competencies, like outreach, communication skills, education facilitation skills, individual and community assessment, et cetera. So like the kind of core CHW training. But then what we did was we bolted on about 24 hours of HIV specific training onto that, along with about 10 hours, and I think is relevant for this conversation, about 10 hours of SUD training. Now that doesn't have to be that way. For a different model, for a different location, for a different state, for CHWs in a different place, or who are going to be addressing a different issue, you could bolt on anything there. But I think it starts with the training. I think that if we're going to have CHWs addressing HIV, there has to be some sort of relevant training in place. And I think that can be done in a relatively straightforward way. But they're going to need to know what it is they're talking about. I think one of the opportunities that our particular we've graduated 185 community health workers in 2023 from our 6-week CHAMPS training program. One of the opportunities there, since we're talking about syndemic, and we know that HIV, hepatitis C, and substance use disorder sort of amplify one another and are interrelated in this way. We just kind of got the final statistics in from our 4 cohorts as we're running the end of the year numbers. 53% of our graduates were people who identified as having substance use history, or otherwise identified in some way as being kind of in that realm. So when we think about community health workers, what we're doing with community health workers is not training professionals to parachute in and say, here's the answer that you need. What we're doing is we're training community members who already have existing trust relationships with the community. and that they can leverage the trust relationship in a way that a doctor with a degree, as much as I value and think that that's important, and all that education is so crucial, and I don't devalue that, but we know that from a persuasion perspective, those existing trust relationships are crucial. So we get some training into these CHWs with these trust relationships. They can go back into the community and do all kinds of things. Some of the ideas that I've heard recently, and something we're looking at for 2024, is looking into an additional sort of module, an additional bolt-on module for PrEP navigation. So that would be a way to, that would be one potential way to help address the SUD crisis, as I heard Shannon kind of refer to earlier in West Virginia, of HIV and the syndemic at large. We know that the CDC has said we had 149 cases of HIV in 2021 in West Virginia. In 2022, we had 210 cases. Dr. Fauci found an opportunity to comment on that's how big of a deal it was. That Dr. Fauci had a reason to sort of comment on the increase in cases in West Virginia. We know that in the middle of November sometime, at that time they were counting, it wasn't CDC yet, the West Virginia Bureau of Public Health was counting 83 new cases for 2023. So we know this is sort of ongoing. But we have people, we're training people who are already in place to leverage those relationships. And now it's just a question of giving them marching orders. And that has to do with grant funding. That has to do with, programmatic. How do we sort of marshal these forces that we now have in place and get them headed in the right direction? I think that's a really important question for 2024.
Awesome. Thanks for that, Jason. Shannon, I'm wondering, as someone who's really directly on the ground, like sort of serving your local community, do you see a role for community health workers to play a role in addressing and supporting the harm reduction work and broader public health work you're doing?
Definitely, but I think it is imperative that they are really screened well, because I'm sorry, I forgot his name. The one who was just speaking. Is it Jason?
Jason, yeah.
Having people with lived experience can be a blessing, because you do already have those connections. However, some people with lived experience when dealing with this population, you can't have any ulterior motive that, hey, I'm going to convince them to do this or do that, because this is especially the unhoused, our population that are consistently, looked down upon, and people try to take advantage or manipulate or minimize anything they're going through. And if they feel that you have ulterior motives when you come in there, you've lost your opportunity. I think it is imperative that community health workers have all the resources and what have you, are able to bring up things like PrEP or harm reduction or what have you, but in a way that isn't like, hey, you should really do this, but in a way that, hey, if you're interested, let me, share this with you. So it can be something they decide to do versus feeling pressured to do. I don't know if that answered your question.
Yeah, that was great. Thank you. And, Dafina, you sort of sit at this work, from looking across the entire region, live in South Carolina, but looking particularly, at the South, which has strong overlap with Appalachia. What role do you see community health workers playing in combating HIV?
Yeah, I think all the responses and everything I've heard is aligned with what we've seen from a regional level. What this brought up for me, though, is the gap that community health workers fill when we're talking about we'll talk about HIV care specifically. So often what we hear folks say is that they don't feel seen in their care spaces, that they don't feel seen or understood. And what we often hear around the engagement with community health workers is that value of being seen and that value of being understood, which will likely lead someone to continue in their care, right? And so I think that we don't give enough value to understanding the role that community health workers can play to keeping folks engaged and retained, not just in care, but just engaged around thinking about just their health holistically and that feeling of worthiness. We don't talk about worthiness enough, whether we're talking about someone who's dealing with a substance use disorder, or someone who is dealing with an HIV diagnosis, or both, or more things than that. That worthiness is directly connected to the likelihood that someone is going to seek care and remain in care and believe that they can do those things. And so just from a practical standpoint, there is so much inherent value in having folks with lived experience who are vetted and also allowed to build skills so that they can do the work well. I think too often we say, you've got lived experience. Oh yeah, you know the story, rubber stamp. But we have to build programs that help to build people's skills so that they can have a livelihood, so they can build careers. And that's something from a regional lens that we talk about a lot, is how do we reduce barriers to those opportunities for folks to build and grow their skills, while also making sure that we are effectively vetting and setting clear expectations. Because we have to remember, when folks are often coming from experiences that have historically marginalized them, but they've had limited opportunity, so much of the expectation in a system might be new. And like, how can we be empathetic to that while also creating like really clear standards and expectations? So, but I think all of that is worth it for what community health workers bring to the lives of the folks that they serve and touch.
Yeah. I want to lift up as we sort of head toward the end of our discussion today. So we've, started to get some great sort of thoughts, questions, ideas in the chat. Welcome anybody listening in. Like, please drop additional comments, thoughts in the chat, or if you'd like to speak up, just, raise your hand. Saw a comment about, thinking about sort of jail settings and correctional settings. We know so many funds are headed to the prison industrial complex in this space. One thing our team is doing a lot of work on is monitoring how opioid settlement funds are being spent across all 13 states. See, unfortunately, many communities thinking about these as opportunities to fund jail bills, right? Outstanding, costs in the correctional system. This is, I think we all know this work is a public health issue and that we just aren't going to arrest our way out of it. Do any of y'all have thoughts about that question, about how we think about diverting funds away from jails and prisons? Shannon, you seem ready, so.
Oh, yes. At the DPA conference, I was at the Appalachian Settlement Fund meeting that they had. And I about lost my mind when I found out one of the states, a county in one of the states receiving settlement funding, spent $24,000 on a drug dog. Now, these funds are not supposed to be, utilized for criminalization. They're supposed to be utilized towards, prevention, treatment, and things of that nature. And criminalizing a substance use disorder has failed miserably, and I don't understand why we're continuing to follow this path. It just, the more we crack down, the iron law of prohibition, the more we crack down on a substance, the more dangerous it becomes. We're seeing this with opiates when they cut patients off from their prescription. They went to heroin. Heroin has a life cycle. So in order to, keep up with the demand, fentanyl was introduced because it can be made in a lab. And now we have this xylazine. And it's like the more they crack down on opiates, the more poisonous the drug supply got. And it's like, we need to stop criminalizing it. We need a public health approach. And my big comparison is the diabetic who eats themselves into a diabetic coma and has to go to the hospital because their glucose is 400 or 500, doesn't get arrested. But the person with a substance use disorder who overdoses and needs to get Narcan has a great chance of being arrested. And it's like, this is a mental health issue, and I think until society and our government realizes the war on drugs is a dismal failure, And we shouldn't be putting money into prisons to lock more people up who have a medical condition. You know, it's just going to be the same game over and over and over. Yeah. I don't think any of the money should go to law enforcement, honestly. I think it should all go towards the people who were pumped full of prescription opiates and then, you know, cut off and had to turn to the street. The doctors knew what they were doing. The pharmaceutical companies knew what they were doing. And now, you know, a lot of people with substance use disorder are the ones who are paying. And then they're going to be putting money into jails to put us in there when the government, the pharmaceutical companies, and the doctors did this to our country. Sorry.
Yeah.
That's something.
I know you asked that question. I saw you went off video, so would love to hear from you, and then Fran, I'll pass it to you.
Oh, yeah, hi. So, I would say, it's a cultural shift. We as Americans, we're reactionary. We wait until there's a big problem, then we want to throw some money at it, more money than, we have to. We criminalize. We know that there are other countries we can look to for policy change. We know that Portugal has diverted money from penalizing people for substance use, individual use. Of course, it's different when, you may be distributing drugs or whatever the case may be, but individual use, rather than arresting them, charging them, putting so much money into that system, diverting that money into training them, into getting them treatment, into helping, with HIV testing, whatever the case may be. We know Canada has programs as well. So until we have that cultural shift and policy change where we are actually working more on prevention than, than reaction, I think that we just need to keep fighting, for legislation changes, for policy changes, for rethinking, what we do. And, Shannon and I know each other. We practice in the same circles. And, we see, we have day reports. So yes, they do help people coming out of jail, coming out of institutionalized, criminal situations, and, spouting how much money they saved because of day report. Well, if we didn't criminalize substance use to begin with, we wouldn't have to be saving money from the criminal system, for recidivism. So, and the whole peer, thing. Yes, we do need peers. We need peers. We need people with lived experience, but we also need educated, trained people, as Dafina had said. We see a lot of practitioners out here, people out here, for instance, and I hate to call out, and I hope this person isn't on this meeting, but, having lived experience may not make you qualified to be the director for day report. So, especially when, you have your own model for recovery, when that may not be the only model available to the public. So, it's a lot of work. And, us meeting here and talking about this and getting in for the legislation piece, I think is so important.
Yeah. Fran, let me pass it off to you.
Okay. So I don't know in Virginia or West Virginia if there is what's called the Angel Initiative. Has anybody heard of that? You can raise your hand. But in Kentucky, there is what's called the Angel, and I'll put the link here that talks a little bit about it. But a person can actually come into any state police post in the state of Kentucky and say, I have an addiction problem. And even if they have their drugs on them at the time, they're not arrested. They are, of course, they get rid of the drugs, but they are taken that day. They are assigned to a facility for help. And that seems to be really what the problem was, is we didn't have beds to get people in. There was like a wait period. When someone come in and said, I need help, they had to wait so long that they lost their drive to get help at that time. So the Angel Initiative, and I put the link there for you, in Kentucky has been one. I agree that, and that's not, there's no funds out of this settlement money going to that. But I think we do need to be inventive about ways and places where people can go to get help. That's an unusual one, to be able to walk into the state police post and be able to do that anywhere in the state of Kentucky. So I just wondered if anybody else had that, something like that going on, where people could actually walk in and ask for help.
What happens if they leave the facility they're sent to AMA?
If they leave, if they're sent to do AMA after they get in treatment, I'm
do
not
the
sure.
police follow up?
Yeah, I don't think the police have anything to do with that. That's pretty much, they go, they get them into treatment. I'll follow up on that to see, but I think that their point is, let's get them into treatment instead of arresting them today, you know, and see if we can't. In Kentucky also, we passed a legislative law about opioid use, and it sort of backfired if you go back and look at the things that happen. So instead of the doctor prescribing what they need, then they go on the street and they get what they think they need. And it's usually a higher dose than what they need. And that's why you see all the overdose things that are going on. People that have been in prison for a while and they get out and go to the street and get their first dose, usually overdose because they haven't had it in a while. There's all kinds of things about prison, coming out of prison, treatment. Some of the things that we did in legislation really backfired. And I think we really look at those.
I know I'm dealing with something similar back in the day. You know, like so many people, I started my substance use with prescription medications and it went crazy. My daughter, 26 years old, has a very rare and painful bone disease, polycystic fibrous dysplasia. She actually had rods in her femurs, tibias, plates in her hips. November 13th, the rod popped through her femur. And then again, March 13th, and then again in November, we had surgery last week. And then she fractured her other leg yesterday from compensating from the leg she just had surgery on. Well, the issue is I've been on both sides of the fence for the prescriptions, but the legislation and all of that, I understand it's to prevent people like me from abusing the system. But when my daughter refuses to take her pain medication because, you know, she doesn't like taking it, she doesn't want to run the risk of becoming addicted, but then when she needs it, they like side-eye her and give her such a hard time when it is visibly obvious that she has pain. I mean, she does not take her medicine unless she absolutely needs it. And it drives me crazy because I'm like, just take your medicine. But, you know, seeing them try to demonize my daughter for pain when she never abused her medication. We have the same thing happening with, you know, veterans who are committing suicide because they're cut off with their pain medication. I think when we make legislation regarding how to treat patients, it's always going to backfire.
Yeah. Well, and
It's
two, you
my
bring up a
opinion.
really good point. We really need preventative education with our providers, because if you walk into any emergency room with pain whatsoever, I had kidney stones a couple of years ago. Don't wish that on my worst enemy. And I've been a nurse for years. I know exactly how to treat it. And the first thing the doctor said to me walking in the room was, what kind of pain medication are you after today? And so, you know, we need to do education with our providers as well, not just our communities, but how do you talk to people and how do you not stigmatize them yourself when you're giving treatment?
The pendulum definitely swung too far in the other direction, unfortunately.
I mean, I think what this conversation's speaking to, right? You know, that I know we've got some conversation in the chat too about sort of potential legislative, both opportunities, but threats in 2024 is, I do think those of us working in a syndemic space, right? Thinking about how we support folks who have a substance use disorder, who are struggling, you know, with addiction, is that this is a public health problem. And so often, right, we treat this as a problem that needs to be handled in the criminal justice system. And those outcomes just are not helping any of us. They're not helping the person who may be along a spectrum of what they're looking for and what resources they need. They make this more expensive and they make it more challenging for our system in the long term. Riley, I noticed you went off camera. Were you interested in asking a question or sharing anything in the conversation?
I did. Well, I was off camera and I'm on now, and I started typing, and I'm long-winded and like I've been typing this whole time. I did really just.
And why don't you introduce I know we've had Access Point on before, but introduce yourself.
Yeah, I'm sorry. I'm Riley Kirkpatrick. I'm the executive director of Access Point of Georgia. We're a harm reduction program. We do all kinds of things. Yeah. The conversation earlier regarding like kind of the competitiveness and this like not like scarcity mentality as opposed to abundance. And I just was thinking a lot about that, and there just was some commentary around like how I heard it was kind of like the value of peers, and whether it's peers or whatever, it really doesn't matter. Like, I feel like we could insert anything there. I think that mindset, like, this might sound really peripheral, but I don't think it is. I was able to do this new and emerging leadership thing through the National Harm Reduction folks, and they talked a lot about literally like white supremacist mentalities and capitalism, and these mentalities that we are so stuck in that where just like real intense hierarchy exists. And since really learning about that, I feel like I see it kind of manifesting itself in different ways. But and I know these are different conversations because it kind of like forces us to look at ourselves and how we are doing this work and how we work together. But I think it's really easy to stay in those mindsets and spin our wheels and continue clawing at each other. And I know it sounds kind of cheesy, but that whole like whatever you focus on gets bigger. I really believe that. And like, if we focused on the problem, if we focus on, I don't know, like I just would love to see us support each other in such ways that the people that we serve have options. And whether that's, you know, pathways with clinicians or peers or anything, any of it, that's where our focus lies. But anyway, I just went off a little bit. I will not send that epic rant. You're welcome for not sending that. But yeah, that's kind of where I went.
Yeah. No, I mean, as regular attendees of the Appalachian Partnership Consortium know, right? We welcome rants, we welcome stream of thoughts. Like this kind of work, I think we at CEG absolutely believe, right? This kind of work, this type of collaboration, this type of conversation is how we bring folks together, foster new ideas, and create a difference in the region. I want to give Shannon, Fran, and Dafina, you know, we're winding our time down. I would love to give you both each like, 30 seconds, right, to close us out with a thought, an idea, a suggestion, what you're sitting with as you think about how we work with community health workers to combat HIV and the broader syndemic. Dafina, can I pass quickly to you first?
Yeah, sure. Thank you so much. And I want to thank Riley for those comments, because I think it's critically important that we acknowledge the way that racism, homophobia, transphobia, and all of these things manifest in our work and the way that our organizations are structured. And I would just challenge us to think differently, whether we're talking about peers or CHWs or whatever phrasing we're using, that we look at what our overarching goals are. And I know today we're focused on HIV, but it's thinking from a systemic lens really what are our goals and what are the roles that different actors play in us reaching those goals, and recognizing that there is so much value in each of us being at the table in this work. And so just not wanting to lose sight of that, and that we have to fight and advocate for those that have the resources, that are doing the funding, that are making the decisions, to also see the value in the various actors that are necessary for us to change things in our communities. Thanks.
Fran, past you to close us out.
Thank you. So I do think that with our community health workers particularly, that they do need to be trained in a way to handle just about everything that comes their way, and how we can share our experiences, whether it be HIV, whether it's substance use disorder, whatever that is, that if we can share with one another what works and help each other not have to go invent the wheel totally again, that we can actually reach the goals that we need to reach to help the people we serve. And here I'm willing to work with anyone to look at whatever we need to work with to help each other. I do believe in community health workers. I've had them for 30 years. We are training peer support specialists as well as community health workers. The thing I want to leave you with is the training is very important. Supervision is very important. Looking at what's working, what's not working, and trying to tweak that to make sure we move forward is very important.
And Shannon?
I just think, it's important to try to collaborate with whoever you can, educate the community, and definitely call your local representatives and congressmen, and tell them you want change, you want a policy that will work, that's not going to keep killing our loved ones.
Yeah. Well, please join me. Thank you to all three of our speakers. We appreciate your time, and we appreciate the folks listening in. This is obviously our last Appalachian Partnership Consortium meeting of 2023. Be on the lookout. We'll start announcing topics and discussion for 2024 in the coming weeks. I don't believe we have that formal calendar invite on folks' calendar yet, but we'll continue meeting the second Monday of the month, 2 o'clock Eastern Standard Time, 1 o'clock Central Standard Time. If folks have thoughts on, a topic or a discussion, we'd welcome sort of hearing that. Most of you, I believe, are getting emails from Lavina John on our team. Drop her a note if you have a suggestion of a topic or an idea or a conversation. She just dropped that email address in the chat as well. Lavina also shared some info about our Syndemic Summit. We are incredibly excited at CEG about bringing together folks from across the entire Appalachian region in 2024. We're gathering at the Greenbrier in White Sulphur Springs in May for this type of conversation, the work we need to do to plan and prepare about how we are all going to roll up our sleeves in 2024 in the epidemic of HIV and viral hepatitis substance use disorder, do that at the intersection of economic development and workforce readiness. So we hope you'll have marked your calendar for those dates as well. Thanks, everybody. We appreciate y'all joining us, and have a great end of your year. Thanks so much.